Okay, I think that's 5 minutes in. When people come, they'll be able to join, inshallah. So, my name is Jibril, and you guys probably know me already if you haven't seen my face before. So today's session is going to be about ACCS anesthetics, and the presenter that would give the talk about the ACCS, unfortunately, is Sarah El Badawi. She won't be here today, but she prepared a presentation that's pre-recorded, inshallah. So I'll just put that up. But then we have another presentation afterwards as well by Zainab, who is ST7 anesthetics registrar, about to become a consultant. Very exciting stuff, mashallah. And she has her own presentation as well. So we're getting spoiled today, and she'll be able to answer any questions that we may have. I know I've got tons of questions, and you guys may have that too. So I'll put up Sarah's presentation, and then we'll start from there.
Hi everyone, my name is Sarah El Badawi. You're probably wondering why on earth is there a floating head in front of me? um, I obviously can't be with you guys today for the Zoom session, so I'm pre-recording, and I'm just trying something slightly different than normal and hoping it works. So bear with me while I try and get this presentation across to you guys. So I'm just going to enlarge the presentation so that it will show the slideshow. So this is rather weird. But anyway, like I said, I'm Sarah El Badawi, and I'm one of the ACCS Anaesthetics trainees. I'm going to talk to you today about ACCS anaesthetics and actually just getting into anaesthetics because essentially you apply to the same program. And then I'm going to talk to you just a few tips and tricks of getting through the application process and interviews, things like that. Um, so, as I mentioned, I'm just going to chat with you about anaesthetics, getting into it, what my day to day on calls are like. But just a bit about me. I actually studied undergraduate medicine at Peninsula Medical School and I graduated in 2017. I am currently ACCS CT2 and I'm working at George Eliot Hospital in Nuneaton. I can't really tell you why I chose not George Eliot, anaesthetics. Um, it was sort of a process of elimination, if I'm completely honest. And I kind of had to do a bit of soul searching across most things off the list, if I'm completely honest. I just came to realize that I just really preferred a practical hands-on specialty where I'm dealing with, acute presentations, but also had a reasonably good lifestyle, if I'm completely honest. So, just a bit about what an anaesthetist does. So, um, most of you will know sort of the anaesthetist is the doctor that puts you to sleep for an operation. That is completely true. Um, so most anaesthetists are sort of trained in or have a subspecialty in some kind of um, surgical specialty like trauma, orthopedics, pediatrics, obstetrics. So they are essentially the physician that gets you through your operation, responsible for perioperative care. So that's from the pre-assessment before you have your operation until you're in recovery, and that includes sort of optimization um, of patient medical management as well as surgical management. So they'll do the pre-assessment, make sure everything's okay, and then they'll obviously intubate you or do whatever airway management that needs doing. And then you look after the patient in recovery. So any post-op analgesia that they might need, or any further medical investigations, that may be required as a result of something that's happened in the operating room. Um, we're kind of responsible for that. obviously a lot of anaesthetists are ITU trained. Most ITU doctors are anaesthetists. Um, it kind of goes part and parcel with the training for airway management and intubating and ventilating a patient for respiratory support. But obviously we do um, organ support in ITU as well. So renal replacement therapy. Blood pressure support, inotropes, that kind of thing. So acutely unwell patients, we manage emergencies all the time, and we have sort of an understanding of physiology. So those kind of go part and parcel together. But obviously, you do find medics that are becoming ITU intensivists. So yeah, it's not the be all and end all if you just want to do ITU, but the skills sort of go hand in hand with anaesthetics. And obviously, the last, well, not the last, but last point I want to make about what anaesthetists do is, they take a large role in pain management, and that includes regional anesthesia, which in the operating room, if a patient needs sort of prolonged analgesia for their operation, like a particular nerve block for a knee operation. There's lots of anaesthetists that have expertise in that, and also sort of chronic pain management. So you get chronic pain clinics that anaesthetists run, as well as acute pain management, and they're often in charge of the acute pain team that you may find in hospitals. So yeah, I just wanted to list sort of the skills that anaesthetists have or acquire, and that's sort of airway management skills. As you know, they intubate, ventilate, nasal fiber optic, whatever, anything that requires special or specific airway management. That's your anaesthetist forte. Managing acute emergencies. Obviously, there's loads of things that can go wrong in the operating room. So anaesthetist needs to be able to manage those kind of things. So anaphylaxis, laryngospasm, hypotension, cardiac arrests. Those kind of things are again something that anaesthetists develop a lot of skill in, a lot of experience in. Manual dexterity, the reason I put that in is because it is a very procedure heavy specialty, and if you like practical things like I do, then it'll be right up your street. A lot of the things are repetitive, but I really enjoy putting in A lines and all kinds of things like that. I don't find it boring. So as long as you enjoy that kind of thing, um, anaesthetics is a place for you. Ultrasound skills, you kind of have to get good with an ultrasound. Obviously, you're trained to become good at ultrasound, because there's lots of ultrasound guided procedures like nerve blocks um, and IV access central lines. Those things all require you to have some kind of proficiency in ultrasound. And then, as I mentioned, obviously, the thing that sort of ties everything together is having a good understanding of physiology and pharmacology, because all the medications that you give will have an immediate effect on the physiology. So you have to use your knowledge of pharmacology and physiology on a very frequent basis. Obviously, your exams are the mainstay of acquiring that knowledge, but yeah, you'll see it when if you guys start training. It's you've got your cogs ticking around, which is another thing that I really liked about anaesthetics. So my typical day on an on-call is essentially In the morning, I'll pick up the bleep and I'll pre-op assess a patient if they haven't already been pre-assessed by the night doctor. Make sure that they're optimized sufficiently. If they need hemoglobin, if the hemoglobin's low, I'll arrange for a transfusion. If they need fluid resuscitation, if they're really unwell, they're a sick perfed DU and need fluid resuscitation, or even starting inotropes or vasopressors before the procedure, I'll get involved in that. And dealing with, essentially, I just spend my day in the emergency theatres looking after the patients that are having their procedure. If the patient's sort of at ASA1, ASA2, I'll often, because they're not that complicated, be left on my own. Once obviously you've got your competencies to be left on your own, I'll be allowed to sort of intubate and look after the patient, anesthetize them myself, and then if there's any complications, there's always a senior around. But you actually take on quite a lot of responsibility once you get your competencies signed off early on. Liaising with specialties. So I wouldn't say I do list management per se, but if, for example, I've assessed a number of patients and they're on the list for that day, if they are one's sicker than the other, I'll speak to the orthopedics teams and actually say, I'm sorry, there's a really sick laparotomy that has to go before your case. So based on my assessment, you'll have to just wait while we do this case. And then last but not least, the cardiac arrests I attend because I carry the cardiac arrest bleep, and I only attend them if I am not completely tied up in theatre. If I've got someone with me, like a consultant or another reg or another SHO that can sit with the patient, I'll go and attend the cardiac arrest bleep. But yeah, if it does happen, you go and you manage the airway and intubate them if required, and escalate the situation appropriately. So I'll just move myself to one side. So obviously there's a few differences between the ACCS and the core program. I can't really speak for the core training program, obviously, but I know that obviously it's shorter. The reason being is that with ACCS, you have 1 year that's in year one, in the first year, you do 6 months of anaesthetics and 6 months of not 6 months of anaesthetics, sorry, 6 months of acute medicine and 6 months of emergency medicine. So that's part and parcel of the ACCS program. The second year is actually anaesthetics and ITU, 6 months each. And those 2 years, you're kind of treated as sort of the same as the ACCS trainees, but so by ACCS trainees, that's the acute medicine trainees and emergency medicine trainees. You're all doing the same 2 years to start off with. But because I'm an anaesthetics trainee and I've sort of started my anaesthetics training, you get treated as sort of a CT1 in anaesthetics, even though my title is a CT2 in ACCS anaesthetics. So it's a bit complicated, but essentially you just spend an extra year and you do acute medicine and emergency medicine in that first year. Other things to mention with the ACCS program that I haven't written on here is that the ACCS program, you have different things that you get signed off because you are almost seen as someone who's got acute medicine and emergency medicine competencies. You have to get those signed off. So those things sort of include having been signed off for external pacing, DC cardioversion, pleural aspiration, chest drains, the same sort of things that an acute medic might do, or a A&E trainee might do, we have to also get those things signed off. So essentially, you could argue that you've got additional skills, and that's one of the bonuses of doing ACCS. Obviously, it does mean that you're doing an additional year, and some people would rather kill themselves than be a medical SHO again for 6 months. But there is a light at the end of the tunnel. It's only 6 months, and the experience that you gain from it is, you know, priceless. So that's the main kind of caveat, as far as I can see, that makes ACCS different from the core training. The other thing to mention is that, ignore the numbers, those numbers aren't quite correct. But the other thing to mention is that there are, in England and Wales, there are more places for ACCS in England, but it does depend on the deanery that you're going to. Because, for example, East Midlands, while it's quite a large deanery, doesn't have that many ACCS training posts for some reason, whereas it does have much more core anaesthetic training posts. So if you are dead set on a certain deanery, it might be worthwhile, considering what anaesthetics program you apply to. You obviously, when you apply, you actually apply to both. So when you are on Oriel, you're looking to apply for anaesthetics, you click on, I want to apply for anaesthetics. When you apply, you get access to all the ACCS and the core training programs. And then once you get through sort of shortlisting and things, you can sort of bin whichever ones whichever regions you don't want, whichever jobs you don't want, and go from there. But ultimately, if you were to not have any limitation on your where you want to end up training, there are more ACCS jobs than there are core jobs. So it's worthwhile just having a little look at what the availabilities are. I believe everything that I'm talking about is on the ANRO website. So just take a bit of time and look into that. The other thing that is also a benefit of ACCS versus core is that if you're interested in ITU and having sort of a dual accreditation in ITU later down the line, the 6 months of medicine component actually fulfills one of the criteria for your training. So if you do go down that route, you actually save yourself 6 months of doing medicine. And if you were sort of an anaesthetics reg, you would be doing a SHO medical job, which is a bit awkward then if you're a senior anaesthetist and then getting kind of demoted to the donkey medical SHO. You kind of get it ticked off early and don't have to subject yourself to that. But yeah, like I said, negative is an extra year, and if you could absolutely never imagine yourself doing another 6 months in emergency medicine or acute medicine, then maybe ACCS is not for you. I was personally of that cohort, but I applied to both just because I wanted to get in a specific deanery, so I didn't want to limit myself, or specific deaneries, I should say. I didn't want to limit myself just because I really, really hated acute medicine. So yeah, the obvious benefits is that it's quicker to just do core, and you kind of just get stuck into things and don't have to faff about with other things. But you could argue you don't get the added experience and the added confidence and sort of slickness managing acutely unwell patients that the ACCS trainees would get. So it's up to personal preference, and just have a think about what it is that you want yourselves. Are you prioritizing a deanery, or do you just want to get where you can get? So that's that. Ooh, oops. There we are. So I'm not going to get too much into this, but essentially just the entrance exams for anaesthetics. Um, it's really boring. I haven't sat my primary yet, but I'm planning to this year, hopefully. But essentially, to become a fully qualified anaesthetist, there are 5 exams that you have to sit, and during your core training, there are 3 exams: an MCQ, an OSCE, and a structured oral exam. So it is exam heavy, and they are not the kindest exams. There's lots of physics, pharmacology, physiology. You have to get your head down, but there's exams in lots of specialties. So it's up to you. If you really, really, really struggle with exams, and you absolutely hate them, never want to have to, you want to have to sit as little exams as possible, then yeah, this might be a tricky one for you. And the Royal College fees for all anaesthetists in training is £185 per year. In terms of actually sitting the exam, again, not going to get into it too much, but I've been told, and I see now that I've started, and there's not much benefit in sitting the exam before the program because things are just not going to make sense to you. It's very like specialized, like learning all the different equipment, and just none of it's really going to make sense. And yeah, takes quite a while to study, and you pretty much have to say bye to your social life. So, just waiting for the next slide. Right, so again, how to actually apply and what you need to apply to the core training or the ACCS anaesthetics programs. Everything's on the AMRO website. There is a specific PDF that explains the person's specification, so it's really useful to have a good look. As far as I could see, I had a look at the core anaesthetics person specifications, and I had a look at the ACCS anaesthetic person's specifications, and I couldn't really see any difference at all, if I'm completely honest. The key thing though is if you have more than 18 months experience in anesthetics, that's not including sort of a foundation job, by the time you intend to start, you're actually not eligible to apply for the core training. You automatically kind of become too experienced for the core training level, and therefore you have to apply to the ST4 level. But there's obviously, you can't just go straight into apply for the ST4 level. There's certain specifications for that as well. So you have to if you have had over 18 months experience, but you really want to carry on training in anesthetics, then you might have to just carry on working in that non-training post that you've been working at, and fulfill the other criteria, sit all the exams that you need to sit, get all the leadership specifications and requirements, and whatever courses. That would be the way that I suppose you'd enter, as far as I know, from a higher level. But yeah, you have to have 18 months or less to apply for the core ACCS or anesthetics. So things have slightly changed since I applied in 2019. obviously since the pandemic. Um, there's no longer a self-scoring system, as far as I know, for applying to anaesthetics. There used to be sort of a sheet that you filled out and you scored yourself based on your what evidence you had in your portfolio, and that's things like dedication to anaesthetics, or showing your interest in anaesthetics, what audits you've done, how have you closed the loop. You get more points with the as you go down, and sort of if you're a first publisher of um, a a clinical trial or something, there's lots of different points that you can score on each of the domains. So you would go through your portfolio and see, oh, okay, I've got that, I've got that, I've got that, I've got that, and score yourself accordingly. When you go to the interview, they then compare. They have a look at your portfolio and decide if that score matches what they, or what you've written on your self-assessment. And then they, obviously with the interview, they'll have different other things that they look for to assess you and deem you an eligible applicant. But ultimately, there are some of these things, such as the audits, teaching and leadership, you would need to mention them in your interviews, and I'll get into the interviews in a second. So again, because I applied pre-pandemic, things are slightly different. So I didn't have to do an online interview. I did a face-to-face interview. But from what I found online, and you guys can have a look yourselves for a bit more information than what I'm providing. The online interviews, they compose of a clinical part and a general part. I don't know what the general part exactly entails. I imagine they'll ask you a number of questions, such as, tell us about a time that you found challenging, that kind of thing. But the clinical part will most definitely be sort of a clinical scenario, and them assessing you on how you would manage it, and maybe asking you different questions, challenging you about it. For me, obviously it was a face-to-face interview, but they did ask us about clinical scenarios, and they questioned us in depth about our portfolio. So you had to know that really well. Obviously, with an online interview, you don't have the opportunity to show your portfolio, but you will still need to have experiences or evidences that sorry about that, that will you'll be able to speak about in your interview. So the scoring is actually in this order. They are looking for evidence of commitment to specialty. So when you have that general part, I imagine they might ask you, what evidence do you have in terms of commitment to specialty? Reflective practice, they're looking for you to show evidence of your reflective practice. So you can talk about a time where you learned it was a challenging situation, you learned something. Those kind of things are what they're looking for. So decision making, team working under pressure, those are things that both clinical and the general part they'll be assessing. So you've really got to use this opportunity to just give as much as you can in that 30 minutes, that will where you can showcase your decision making and team working abilities. And they might also ask about different qualifications and experiences, and what QI projects you've done and what you've learned from them, and that will sort of add to points. And then of course there's the MSRA, where you sit a nasty 3-hour exam, and it counts for 15% of your total score. I didn't sit the MSRA, so unfortunately I can't give you any advice on that. And I think I would probably not be here if I had to sit it. So good luck to you guys that have to sit it. There we go. So yeah, as I mentioned, the MSRA exam is going to be a bit of a headache for you guys, but it's important to prep for it if it can be prepped for, that is, and speak to people that you know have sat it and get their 2 cents on the situation. Yeah, competition ratios. It's it's not the most competitive specialty, but it is getting more competitive. Luckily, the competition ratio is reasonable because there's so many posts, but there are a lot of people increasingly that are applying for anesthetics. And lastly, if you guys have any questions, please feel free to email me. I'm really sorry that I couldn't be there face to face to answer your questions, but please don't hesitate to contact me if you have any further questions or want any advice on anything. Best of luck to all of you, and take care.
Can you all hear me?
Yep.
Perfect. I'll share my screen.
Yeah.
Can you see my slides as well?
Yeah.
Yeah, perfect. So, so I'll be talking about the anesthetic portion of this talk. Just a little bit of an outline what I'm going to talk. I'm just going to introduce myself, talk about my role, talk about anesthetic training in the UK, a little bit about the FRCA exam, because I have done that now, so I can talk a little bit more about it, and my tips for success in terms of the application. And then at the end, I'll take some questions. So my name is Zainab. I'm an anaesthetic registrar, currently in my final year of anaesthetics training. I train in London, so I'm currently working at UCL in a small hospital called the National Hospital of Neurology and Neurosurgery. I'm currently doing my neuroanaesthetic fellowship, and I'm a fellow of the Royal College of Anaesthetists. I've trained, most of my training has been in London. I went to medical school at Barts in London, and I've actually never really left after that. I've done most of my training in East London, so I've had the privilege of being at the Royal London, where I've done a lot of neuroanaesthetic trauma and a lot of very interesting anesthetics. So all the major events that have happened in London, 7/7, I was at medical school, and all the terrorist attacks that happened in London, I was always at the Royal London, so they all came through our doors. So you end up getting a lot of very good experience in trauma. We also have the helipad, so we get all the very interesting trauma that comes through. I've also had the privilege of training at Barts, which is the other sister hospital of Royal London. They mainly do cardiac in that hospital. It's also one of the oldest hospitals in the UK. Very, very good place to study. And although it looks very old from the outside, on the inside, it's quite new for those of you who haven't been to it. So what do anaesthetists do? Mainly my job is a few things. Number one, I go see patients every single day and process them for clinic and for theatres. Our job is mainly to assess patients and see if the patient is fit enough to have surgery. We usually see patients the day of surgery. So in the morning is the first time I meet the patient. We go through all of their notes, and we basically decide if they are fit to have surgery on that day. Sometimes the answer is no. If, for example, they're not medically optimized enough, as anaesthetists, we're usually the first people to put all the patient's medical notes together. We're often the first person that has looked at the surgical letter, that has looked at the GP letter, that has looked at all of their medical notes and said, okay, is this person fit enough to have surgery today, or do we need to do something to optimize them? So sometimes it might be somebody needs to go back and have their hypertension managed or their diabetes managed, or maybe that person needs to go to ICU and be optimized before they come to theatre. As you can see in this picture, there's a man on a bike. One of the things that we do is pre-assessment clinic is we test people's physiological reserve, and that lets us know how they're going to be able to do in surgery and whether that person needs to go to ICU post-op. As anaesthetists, we cover just about every single specialty that you can think of. We do cardiac, we do pediatrics, we do obstetrics, we do neuro, we do every general surgical procedure there is. We anesthetize people for MRI, endoscopy, whatever. If anything you can think about that somebody needs to have that's a bit painful, we're usually involved as an anaesthetist. And what that means is that we have to be quite skilled enough to be able to anesthetize anybody from a newborn baby all the way to somebody who's, you know, an elderly, frail patient. And so you become very adept at managing people's physiology and thinking about their anatomy and how all of that interplays into being able to have surgery and be safe. As I said, we do a lot of obstetrics. We provide labor analgesia. We also provide anesthesia for women who are having cesarean section. Some of my colleagues, all anaesthetists do pain, so we all have to do acute pain because we anesthetize patients for theatre. But some of my colleagues have a particular interest in pain and they go on and do and subspecialize in chronic pain. As anaesthetists, we become very adept at dealing with emergencies. So I spend a lot of my time when I'm on call in the A&E department or in cardiac arrest situations, either leading them or certainly doing the airway part of it. And again, that means anybody who arrests in the hospital, whether it's a child, to an adult, to a pregnant woman, it doesn't really matter. We're usually involved as a specialty. As anaesthetists, we also cover intensive care. So you become, and that means we cover cardiac intensive care, we cover neuro intensive care, we cover general intensive care. Unless you're particularly interested in pediatrics, we don't really do pediatric intensive care. As an anaesthetic registrar, you don't do that, but as a consultant, if that's what you want to do, then you can subspecialize in pediatric intensive care. We're also very much involved in transporting patients. In my day-to-day job, I'm always transporting people from either A&E to ITU, from ITU to the CT or MRI scan. And in some cases, we even transport patients from one hospital to another. So for example, if a patient comes to a hospital and has had a stroke and they're not managed in that hospital, or they've had an MI and they can't be managed in your hospital, oftentimes we transfer them out to a hospital that can deal with that. Some of my colleagues are very much interested in pre-hospital medicine, and so they are involved in pre-hospital care, and they're the ones who travel via helicopter or cars and go to the roadside and provide anesthetics on the roadside. Usually they tend to be people who are very much adrenaline junkies. Just to add an extra layer of interest in anesthetics, they do that. All anaesthetists are very much involved in teaching and training. So as part of my job, I'm involved in training and teaching not only my colleagues, so my anaesthetic colleagues, my junior anaesthetic colleagues, but medical students, anaesthetic nurses, theatre nurses, midwives, just about everybody that you can think about. We're very much involved in their teaching and training. And I think anaesthetics is a very good specialty that works with just about every department in the hospital. So you end up becoming quite adept at working with different people and sort of getting on with them and sort of understanding what the needs are, what the constraints of their department is. So for example, I work with oncologists and surgeons and general medics and just about everybody in the hospital. So why would you want to do anaesthetics? I'm sure you all want to do anaesthetics and that's why you're here today, but why would you want to do anaesthetics? I think it's a very good specialty that allows you to sort of mix your practical skills with your diagnostic medicine skills. As an anaesthetist, when you go see your patient, you're looking at the full notes, you're looking at the ECG, you're looking at their bloods, you're looking at their imaging, you're looking at their CT scan, their x-rays, and you're the one who's sort of putting all of those jigsaws together and deciding, is this patient, can this person have an operation? Certainly when you're doing intensive care and somebody's critically unwell and we bring them to intensive care, we look at all of that things, we assess them, we decide on a management plan. Obviously we take input from all the other specialties, but as an anaesthetist, you become very good at sort of knowing a little bit about just about everything. We don't do ward rounds unless you do intensive care, and that's one of the reasons I picked anaesthetics. I don't really particularly like ward rounds. So if you hate ward rounds, anaesthetics is a good specialty to do, except when you're doing IT, obviously. As I said, it's a very broad scope of practice. It offers other opportunities. So if you're interested in teaching, anaesthetics is very good for that because you're constantly teaching other people. There's opportunities to become leaders, and especially in leadership and management. This for me personally was particularly evident during COVID. As anaesthetists, we were thrust into taking leadership roles within our hospital. So we were responsible for sort of just triaging the hospital and deciding where intensive care could expand to, whether we could expand to recovery and how to convert that into an intensive care, and then training our surgical colleagues and our medical colleagues on how to manage very sick patients on the ward, because that's not something that other specialties are very adept at doing in the day-to-day practice. Normally, if you have a medically unwell patient, you call intensive care and then they go to intensive care. But during COVID, suddenly all of those patients had to be managed outside of intensive care. And so we suddenly became leaders in training our colleagues and supporting our colleagues, but also then adapting the hospital policies to be able to cope with COVID. And also as a specialty that deals with intensive care patients and very sick patients, we're very used to using ventilators, and certainly my colleagues who never use ventilators find that as a struggle. And so we were suddenly supporting a lot of people in the hospital. You do learn to work in an MDT, so every day I work with different surgeons and different nurses and different colleagues. So you learn to work with people and you learn to communicate really well with people. As I said, you become very adept at managing critically unwell patients. If you like that, if you like the challenge of that, I think anaesthetics is a very good job for that. You get day-to-day consultant teaching. Every single day I'm working with a different consultant. Every single day I get teaching from a consultant. So if you like that one-to-one interaction, anaesthetics is again very good for that. You do get a very excellent work-life balance. I will say that when you're preparing for the FRCA, the work-life balance is not so great, but afterwards it's actually really good. I start work on time and I usually finish work on time. So what are the skills that you need? You have to be quite good at working within a team. Again, if you're somebody who doesn't like working with different people, I don't think anaesthetics would be a very suitable career for you. You have to be really good at communicating with people, because sometimes you come across people who are quite stressed out and going to a cardiac arrest situation or dealing with an acutely unwell patient. You come into contact with people that are very stressed out, and so you have to learn to communicate with them and sort of be very calm in those kind of stressful situations. If you like learning practical skills, there's loads of practical skills that you can learn in anaesthetics. Just on top of my head, all the nerves that you have to learn to block just to do surgery is just, it's quite a lot. Again, you have to be somebody who can keep calm in a crisis and take leadership. This is particularly in a cardiac arrest situation, and it doesn't really matter where you are in the hospital. If there's a cardiac arrest situation in theatres, everybody looks to the anaesthetist to sort of take leadership, because we're so used to dealing with such acutely unwell patients. And then you have to like working with people again. So I'll just talk you guys through a day, what a typical day of my life is. So if I'm working a normal day, this is why I spend most of my day in the operating theatre. Because I'm doing neuroanaesthetics at the moment, most of my patients are in that particular position or have got clamps in their head. Usually for anaesthetics, we start very early. We start 7:30 in the morning. So if you're somebody who doesn't like starting early, maybe anaesthetics is not the choice for you. Usually I go and pre-assess my patients. So the day before, I usually get the operating list for the day. I look, am I doing neuro? Am I doing backs? Am I doing obstetrics? Am I doing dental? It just varies every single day. And then I go and see my patients that day. By about 8 o'clock in the morning, I have team brief, and that usually means is when I meet my surgical colleagues and my anaesthetic nurse colleagues and my theatre nurse colleagues, and we all introduce ourselves. We discuss the patients on our list. I discuss the concerns I have about my patients. The surgeons discuss what kind of position they want the patient, what their concerns is. We all come to a consensus plan as to the order of the list, and we all come to a plan as to where the patient's going to go post-operatively. So not all patients can go back to the ward. Some patients might need to go to intensive care. Depending on the order of the list, sometimes somebody might need to go first on the list. So we discuss all of that in the morning, and the surgeons discuss with the theatre staff what equipment they need. So that all happens in the morning. For my point of view, I get all my drugs ready, I check my equipment, which means the anesthetic machine, my pumps, all of that stuff, and I have to make sure they're all working. Usually the patient is in the operating theatre by about 8:30 in the morning, and then we do induction, position the patient for surgery, and then the surgery usually starts. Most of my time, I think, because I'm coming towards the end of my training, I usually have a lot of meetings, mostly to plan out teaching that I'm doing or research project I'm writing or something along those lines. But most days I have some meeting with somebody in the hospital. So the good thing about anesthetics is usually it's myself and a consultant. So we take it in turns. If we have meetings to go to, one of us can go to a meeting, the other one can stay. That doesn't happen when you're quite early on in your career because the consultants need to be around to supervise you. But as you become more and more senior and they get to know you and trust you, it just becomes a bit of a collaborative day, basically. If my patient needs to go to ICU, I transfer them to ICU. Most of the times my patient goes to recovery and then goes to the ward. And I usually finish about 5:30, 6 o'clock. If I'm on call, my day is a bit more unpredictable. So usually my shift is longer, it's about 12-hour shift. As I said, it's very unpredictable, and it means I'm holding the on-call plea, so I can be called for anything in the hospital. It could be a cardiac arrest, it could be somebody who's sick in the hospital, it could be to transfer somebody somewhere, it could be to go on an ambulance and transfer somebody out of the hospital. So it really is anything. I usually have my emergency drugs drawn up because it's so unpredictable and I don't really have the time to draw it up in an emergency. And when I'm on call, I cover every part of the hospital. So ICU, neuro, stroke, cardiac, just about anything you can think of. I also cover emergency theatres on some of the days. So my days are either split covering emergency calls outside of theatres or emergency calls within theatre. So that means the surgeons book patients on the emergency list and I go see them and anaesthetize them for that particular surgery. Sometimes, well, not sometimes, most of the times when I'm on call, I am called to review sick patients on the ward. And then I go see them, I assess them, I discuss with the medical team, and I decide whether that patient is sick enough to go to ICU or whether I can suggest treatment plans that they can do on the ward to sort of optimize the patient and prevent them from deteriorating. IV access, we're called for IV access in a lot of patients on the wards. And it's usually patients that the primary team have struggled to gain access on. I do have to say sometimes when I'm busy, I don't have time. But in terms of the priority list, it's I would say at the bottom of my priority list. And then again, I might go on a hospital transfer, and that could be anywhere. If a patient comes in and it's, for example, a burns patient, that might be Bloomfield, so that might be miles and miles away. Or if it's a patient who's come in with a heart attack and they need to go to Barts, it's just down the road. So it just depends what I'm doing and who I'm transferring. And I usually finish about 8 p.m. So it's a 12-hour shift. So usually my on-call days are very, very unpredictable. So I'll talk a little bit about anaesthetics training in the UK. So it's usually 7 years, and there's an asterisk next to that 7 years because some people do take time out for maternity leave, for research, for traveling, for all kinds of stuff. But it is minimum 7 years. And it's recently been changed. They've just called it stage 1, 2, and 3. It's the same number of years. It just has a fancy name. So stage 1 is about 3 years long, and it's your core training years. So it's CT 1, 2, and 3. And in that time is when you learn anesthetics, you gain your initial competencies, which means you show competencies in using the machine to anesthetizing relatively straightforward patients. You also start doing obstetrics towards the end of that 3 years and gain competency in putting epidurals and anesthetizing women for cesarean sections or any gynae operation. You get at the end of that, during those 3 years, you should be doing mostly general or obstetric anesthetics. You don't really do anything. It's not about gaining specialist knowledge in cardiac or neuro. So you won't be doing those, but you'll be doing, general surgery, appendixes, laparotomies, gynae surgeries, whatever. You're expected to have your primary FRCA exam by the end of those 3 years to be able to then apply for registrar jobs. So if you don't have your FRCA exam at the end of those 3 years, you can't apply for registrar jobs. And then stage 2 is usually 2 years long. Those 2 years is your registrar 2 years. So you, at that stage, you start doing some of the subspecialty modules. You start doing general, cardiac, neuro, airway, regional, just name it, just everything really. You're expected to have your final FRCA at the end of those 2 years. Otherwise, you can't progress onto stage 3 of your training. Most people, when they get their FRCA exam, then start thinking about what kind of anaesthetist consultant they want to be. So they start applying for fellowships. So usually that happens in that 2 years. It's a very busy 2 years. And stage 3 is again 2 more years. And you do the rest of your subspecialty modules that you haven't done. So if you haven't done cardiac, you do cardiac, and then neuro, you do neuro. And it's this time that people do their fellowship, which is roughly about a year. Sometimes people do more than 1 year of fellowship, and that's usually for people who do, people who want to do cardiac, for example. Cardiac, you do need more than a year to be able to get all the competencies to become a good cardiac anaesthetist. And it's also the time that you prepare for consultant applications. So it's the time when people start looking at departments and thinking about where they want to work, where they want to live. This is just a slide just to show that when you do your fellowship, it can be anything. So I know colleagues who've worked in mergency ship, which is a mobile operating theatre in a ship, and they go to different parts of the world, especially remote parts of the world. And they offer surgery, and you can do anaesthetics on the ship there. I know some of my colleagues who went to Australia and were flying doctors and were, medevacing patients in the middle of nowhere. I know some colleagues who've gone to different parts of the world and have taught skills and, mostly about training the locals on anaesthetics and, sharing knowledge. So I did something completely different. I actually stayed in England. For me, my fellowship was roughly around the time COVID hit. So I did a research fellowship, and I did my research fellowship at the Royal College of Anaesthetists, and I was fortunate enough to work with big data and work at the Royal College on their national audit project, looking at the outcomes of surgical patients in the UK. So that's what I did for my year, and I had to learn how to code and all that stuff. So you can do anything really for your fellowship year. So a little bit about the FRCA exam, which is everybody's dreaded nightmare. So as I alluded to earlier, the FRCA is made of 2 parts: the primary FRCA, which you do have to have at the end of your stage 1, and the final FRCA, which you have to have at the end of your stage 2. So the primary FRCA has 2 parts. It's got the written and the OSCE Viva, and you have to pass both of them independently with each other to be able to be given the primary FRCA, and then that will allow you to apply for registrar jobs. And then the final FRCA also has 2 parts. It has a written part and a Viva part, and you have to pass both of those independently of each other to then become a fellow of the Royal College of Anaesthetists. These exams are very time consuming. They don't happen every month. The primary FRCA, I think, happens 3 times a year, and the final FRCA happens twice a year. So you can see that if you don't do your exam early, well, not early, but if you don't do your exam within a timely period, you might run out of time for you to then progress to your next stage of your training. So, my advice would be, when you start anaesthetics, start thinking about when you're going to do your exam, and have a think about that, because you can run out of time very easily. So what are my tips for success coming towards the end of my training now? Make sure you look at your personal specification. It does change every year. So whatever year you're applying for your anaesthetics training, have a look at it. Make sure that you meet all the personal specification. Some things you're not going to be able to meet. So if you haven't done a degree before medical school, that's just something you're not going to be able to fix. Forget that. But there's other things you can meet. Make sure you meet as much of the personal specification you can. Show commitment to the speciality. So when I was a foundation trainee and I was interested in anaesthetics, I did a taster week in anaesthetics in theatre. Anaesthetics departments are all really friendly. Just go to your local anaesthetic department and see how you can organize that for a week. Make sure that you update your CV. If you've not got into anaesthetics 1 year, have a look at your CV and think about what you can do in that 12 months to make yourself competitive for the next year. Make sure that you complete your application carefully and early. It is only out for a month. before the deadline finishes. So make sure that you apply early and you fill it in properly. And then make sure you practice your interview. The questions tend to be quite predictable. If you speak to anybody who's already in anaesthetics, people will tell you roughly what kind of questions they ask. And also, if you go to the website, the application website, they do have the mark scheme of the kind of things that they're looking at. So print that out, have a look at it, and then you can see roughly what they're looking at for you to be able to score maximum. And as I said, if you're not successful one year, make sure that you work on your CV so you're more successful the next year. And that's my email. If you have any questions, I'm happy to take any questions you might have. I'll just stop sharing my screen.
Thank you very much, Zainab. That was amazing. I was literally, I was lost in it. I was thinking, you know what, especially with the primary and secondary and the final FRCA, I was thinking about, you know what, this is the exams that people always talk about for, you know, what's the best way. I wanted to ask, there's no point doing the exams like before you start, right? You might as well just do them whilst you're training.
Yeah, you can't. I think the college has rules about when you can do it, and I wouldn't do it before you start. The primary FRCA, I don't think there's a lot of stuff that won't make sense to you. So the machines, there's a bit about electricity you have to learn. There's bits about drugs that you have to learn. I will say that when you start anaesthetics, you can prepare for the written part of the FRCA because it's mostly questions. So it's just repetition. You just have to do thousands and thousands of questions, and you'll be able to see the pattern of questions that they ask and cover the curriculum. So I would say the first 6 months of your anaesthetics training, just focus on learning anaesthetics. It's a very steep learning curve for 6 months.
Thank you, Ola. If anybody has any other questions to ask, please go ahead and ask in the Slido. Alternatively, you can just put it here. There's not that many of us anyway. I have someone that asked, if wanting to subspecialize in pre-hospital medicine, do you have to have a dual CCT in intensive care, or can you just have your anaesthetic CCT?
Pre-hospital has become its own subspecialty, so have a look at it. But it is most of the people I know have done anaesthetics, and then they've also done some pre-hospital stuff. But it's become its own thing. It's not to do with intensive care at all.
Thank you.
Can I ask a question?
Yeah, go ahead.
Thank you very much, Zainab. It's really good talk. Thank you. I just wanted to ask, in terms of, so I've applied before, and you know, all of the points that you said were like completely true. I guess I'm not sure if I'm speaking for everybody on the call, but interview technique is probably something that is quite important when getting into these specialties. Do you recommend like any specific courses, or how would you recommend preparing for the interview?
So the interview has, I think it's now online. It has changed slightly from when I applied, but they tend to ask the same thing. So your portfolio, so they'll ask about audit. So they'll ask about what audit you've done. Have you closed an audit leave? Do you know what an audit is? Do you know what critical incidents is? Do you know what a never event is? All of those things that they love to ask. So make sure you know what those terms are. They will always give you a clinical scenario. So for mine, when I applied for CT1, my clinical scenario was, you know, you're the CT1 on call, you were called to A&E for a 21-year-old who's coming with acute asthma, how are you going to manage them? And I went through A, B, C, D. I start with airway, I give them, you know, I look if their airway is patent, are they able to talk to me? I put them on oxygen, I looked at their SATs, I did a blood gas, blah, blah, blah. So I went through A to E assessment for them, which you all should be able to do because you've all done ALS, right? So I went through that. And so then what they wanted is they said, okay, fine, what else are you going to do? And I said, I would call my registrar, because technically we're still a CT1, right? So you're always going to call for help. So I said, I'll call my registrar. And then they went down the route of your registrar doesn't want to come, what you're going to do. So I said, maybe I just didn't explain the acuity of the situation. So I explained to him that this patient is really unwell and he needs to come right now. And they said, oh, well, he still doesn't want to come. So I said, I would escalate, call the consultant in to come in. And they were like, okay, fine. So tick, that person understands, has situational awareness, is making sensible decisions. So you will always have some clinical scenario. It might be somebody who's bleeding. It might be somebody who's got anaphylaxis. It won't be something too dramatic. They're not going to give you something anesthetic based, but they will give you something a little bit acute, because they want to see, if you look at the mark scheme, there's a bit that they want to see how you deal with pressure, how you think under pressure. As long as you give a sensible answer and it's systematic, they'll say, okay, tick. The other thing they're looking at is your communication. How are you communicating? Is it clear? Do we understand what you mean? Are you thinking in a logical way? So there's a marking scheme on the website, the West Midlands website, which they have, you know, the criteria. You're going to score maximum if you have this. They're not going to give you the scenario, but they'll tell you what they're roughly looking at. And that's the mark scheme that they use. So have a look at it. And I would say, if you've done your taster week in anaesthetics, have a talk to the anaesthetist you're in theatre with. Ask them what questions they had. Are they willing to practice with you? We're very friendly, honestly. We're more happy to help people.
And just lastly, I looked at all of that, and I've done the interview as well, and I actually did okay. But it was my first ever interview. I just didn't rank in the top jobs or whatever it is, so I didn't like get feeded into it. But there was a lot of marks on reflective practice, and integrating that into an interview, like how would you do that? Because now, and in the online interviews, you got like 15 minutes on a general interview, 15 minutes on a clinical scenario. I think there's reflective practice, 20 marks on the clinical scenario as well. Would you just try and whiz through it A to E and then say, I saw this case in, and I reflected on that, and just reflect on a scenario that you saw acutely, or you just speak about the case that they give you? Because
the reflective bit, I obviously, when I applied, it was pre-online interview, so I had face-to-face interview, and my interview was divided into 3 bits, where I had clinical, I had portfolio, and then I had a presentation section. So this was this is different. My advice would be that if I was applying now, when I do my taster week, I'll talk to the CT1s, because they just did that. Right. And get their advice, because they will be able to give you a better advice as to how to prepare for that. My advice would probably be pre-COVID.
No, but it's still useful advice. No, thank you very much.
No worries.
If anyone else has any questions, feel free just to pipe up or ask questions in the chat if you're not feeling if you're up for it. But yeah, that reflective practice one actually was a key point on the interviews. I guess thank you, Zainab. You've explained everything immensely well. It's very nice, mashallah, to see as well Somali ST7 going into consultancy as well. It's very inspiring. So mashallah, and it's amazing to see that. And good luck with your consultancy interviews, and hopefully you'll get exactly what you're gunning for.
Sorry, somebody said somebody has a question.
Yes.
So I don't think it should hinder your ability to do anesthetics. We've got gloves on most of the time, so I don't think it will. That would be my answer.
I've just got maybe a personal question for you, and good luck for your consultant application. What area of anesthetics are you interested in?
Neuroanaesthetics. That's why at the moment I'm in the National Hospital, so I'm very much interested in neuro. I like intensive care as well. I like looking after really sick people. So neuroanaesthetics is just up my alley.
Inshallah, it goes well. Good luck.
I think we have another question in the chat as well. It said, do they look at how long you've been out of training when applying for ACCS anaesthetics?
How long you've been out of training? Do you mean that you took time out after F2 and then you apply for anaesthetics, or? Yeah, they don't, because now it's really common for people to take time out. I would say if you're going to take time out, use your time wisely. That's not to say don't travel, don't do anything fun, but just be really strategic. So for example, if you're applying for the February entrance, maybe the 6 months leading up to that is the time when you're applying for your interviews and stuff, is the time you sort of work on your CV and make sure that your CV is up to date. And then after your interview, you can just go on holiday, it doesn't matter. But always have something in the pipeline. So my advice would be, if you're leaving training, make sure that you've got projects that you can work on, publications and presentations and stuff that can be happening in that year. So it looks like you've done a lot.
I wanted to ask, in an earlier presentation, it was mentioned that if you want to do ITU as well as anesthetics, you need 6 months of medicine. Say you've already got that in your stage 1 training. How many, I know you have to do a different exam, but how long extra would you have to do in your anesthetic training for you to also dual train ICM?
So that is a very good question. So the reason a lot of people do ACCS is because a lot of them think they want to do intensive care. That doesn't mean that you can't do intensive care if you don't do ACCS. So I did pure anesthetics. I could have still done ACCS. What you have to do is apply for, you have to get into ICM training before your ST5 year. And the only annoying thing is that you'll be ST5 and then you still have to do the 6 months SHO medical job. Whereas if you do ACCS, you've already done that when you were an SHO. So you can't get out of that 6 months of medicine that you still have to do, or a year that you have to do of medicine. So yeah, that's.
What about ST5 onwards? Does that add time into your training as well?
It will, because so in anesthetics, you end up doing ITU anyway. I've done neuro ITU, I've done trauma ITU, I've done general ITU, I've done all of that. And my colleagues who are ITU trained, dual training with anesthetics, they have to do twice that. So they will do anesthetic ITU. So it's the same person, but they'll be like, this 3 months is your anesthetic ITU. And then you still have to do another 3 months. And they're like, now you're doing your ITU. And you're like, I'm still the same person doing the same job. So that's what put me off IT. I was like, I've done enough IT. I've got the experience. I don't need to do extra time. But it does add time to your training. So I guess if you're interested in IT, it shouldn't matter.
Yeah, no, of course. That makes sense. Just wanted it. And there's different set of exams as well for that, I'm assuming.
You still have to do the FRCA if you want to become an anaesthetist, but ICU also have to do the FICM.
Okay. And how many parts is that?
It's 2 parts.
2 parts.
And it's usually written by the same people who did anesthetics. So some questions are the same and some questions are ridiculous, but another reason some people do it. And I do have to say that if you're interested in pain, you also have to do an exam to become a specialist in pain. So you still have to do the FRCA and then do the pain exams as well.
I see.
You don't have to do exams for neuro and you don't have to do exams for cardiac or regional or obstetrics, but those ones you do.
When you finish, do you have to sort of pick a specialty, or can you become like a general anaesthetist?
You don't. So you do have to, when you come to, what do I say? So when you want to become a consultant, you kind of have to sell yourself to a department, because hospitals have to do a business plan to be able to hire you as a consultant. So you do have to have some specialty, not specialty, but some interest. So there are a lot of anaesthetists who are general anaesthetists, but they like a bit of obstetrics, so they do a bit of obstetrics. Or they're general anaesthetists, but they like vascular. Or they're general anaesthetists, they like a bit of orthopedics. They all kind of come under the umbrella of general. And then there's the people who are really interested in pediatric anesthetics and they do a fellowship in pediatric anesthetics and then they become pediatric anaesthetists. Or some people are interested in neuro and then do neuro fellowship and then become neuro anaesthetists, or interested in cardiac and so they do cardiac fellowship and become cardiac anaesthetists. So you don't have to, but you can.
Yeah, that makes sense. That's okay. Thank you very much. I think we've covered most bases there. Thank you, Zainab, once again for joining, and inshallah, good luck with everything. Thank you guys for joining as well. You guys could put something in the feedback as well for Zainab as well, and for us, it will be amazing. And we have one more session on Wednesday, psychiatry IMT, and then we're done for this webinar. So yeah, thank you guys for coming. Thank you, Zainab, and we'll see you on the next one.
Good luck, everybody.